This video is based on Autoimmune Inner Ear Disease, AIED, a vestibular physician's deep review, published by Australian Dizziness Clinics. Available at australiandizzinessclinics.com.
Welcome to this explainer. If you're a vestibular physician, neuroaudiologist, or audiologist, you already know we deal with a lot of complex, overlapping presentations. But today we're putting the spotlight on a true do-not-miss diagnosis: autoimmune inner ear disease, or AIED. Why is it so absolutely crucial? Well, it occupies this strategically massive niche in our daily practice because it's actually one of the very few truly reversible causes of progressive sensorineural hearing loss. Missing it? That carries a huge, permanent cost for the patient, so catching it early is paramount. For today's clinical blueprint, we're going to map out 3 key areas. 1. Defining the disease. 2. The historical timeline. And 3. Epidemiology and classification. All right, let's jump right into section 1, defining the disease. So, AIED is uncommon, sure, but it is a highly distinctive cause of audiovestibular dysfunction. Formally, we define it as an immune-mediated cochleovestibular injury that produces rapidly progressive, frequently fluctuating, and, this is key, characteristically bilateral sensorineural hearing loss. Let's just call that SNHL from here on out. And crucially, it responds, at least initially, to immunosuppression. Notice those hallmarks, bilateral and rapidly progressive. That right there is your primary clinical clue. Now, you really have to understand the clinical stakes we're dealing with here. Since there isn't a single magic bullet pathognomonic test to just confirm AIED, and because the presentation can look a lot like atypical Meniere's disease or bilateral vestibulopathy, your active clinical suspicion is literally everything. This disease moves fast, progressing over weeks to months. In fact, untreated patients generally hit severe bilateral impairment within about 3 years of onset. That means your proactive suspicion is the single most important factor for your patient's long-term outcome. And looking at this data on the natural history of AIAD brilliantly illustrates exactly why timing matters so much. You can clearly see the steep, severe, downward trajectory of delayed or untreated presentations. It's just heading straight down toward profound hearing thresholds. But look at the other trajectory. Early immunosuppression dramatically alters that course. It literally arrests the decline. This is exactly why we've got to maintain a super low threshold of suspicion for any bilateral, progressive, or stereoresponsive audiovestibular presentation.
Moving right along to section 2, our historical timeline. It's really kind of fascinating to trace how this clinical entity evolved. It actually kicks off way back with Leonhardt's 1958 anti-cochlear antibody hypothesis. Decades later, in 1979, McCabe published a foundational series of 18 patients, initially defining the condition through its incredible steroid-responsive nature. Fast forward to 1990, and Harris and Sharp managed to detect antibodies against inner ear proteins. Then, we hit a major milestone, Moskiki's landmark 1994 JAMA study. That study successfully correlated the 68 kilodalton heat shock protein 70, or just the HSP70 antigen, with disease activity and corticosteroid responsiveness. Together, these pivotal observations really consolidated AIED as a true standalone disease. Okay, on to our third and final section, epidemiology and classification. Epidemiologically speaking, AIED is definitely rare. Broadly, it accounts for under 1% of all cases of sensorineural hearing loss. But, and this is a big but, it's heavily overrepresented in tertiary dizziness and hearing loss clinics. That's just the nature of referral bias. So as a specialist in this field, you're absolutely going to see it much more often than those population estimates would suggest. The rule of thumb? You should treat bilateral progressive cochleovestibular failure as AIED until proven otherwise. Let's rapidly break down the demographic realities here. The peak onset typically hits between the 3rd and 6th decades of life, so roughly 20 to 60 years old. You'll also notice a very distinct female preponderance. What's absolutely crucial to realize is that these demographics perfectly mirror the demographics of systemic autoimmunity in general. And again, look at that laterality. Bilateral involvement is basically a core defining feature. So you might be wondering, why exactly does this loss of tolerance happen in the first place? Well, the inner ear is sequestered behind the blood labyrinth barrier, sure, but it is not completely immune privileged like we used to think. It actually retains all the necessary machinery for a competent local immune response. The endolymphatic sac essentially acts as the central immunological hub of the labyrinth. It's perfectly capable of antigen processing, uptake, and even recruiting systemic immune effectors directly into the paralymph.
This resident immune architecture is exactly what sets the stage for the autoimmune attack. And because of that strong potential for systemic immune recruitment, we really have to draw a clear clinical distinction between two distinct forms of the disease. Primary AIDD, where the immune process is completely confined to the labyrinth, makes up the vast majority of cases, around 70 to 85%. But then we have secondary AIDD, which represents roughly 15 to 30% of cases. In secondary AIDD, the audiovestibular involvement is really just one manifestation of a much broader systemic autoimmune condition. Think systemic lupus erythematosus, Coggins syndrome, or rheumatoid arthritis. Because up to a third of your AIDD patients will have or eventually develop a systemic autoimmune disorder, doing a directed screening for systemic autoimmunity isn't just an option, it is absolutely mandatory.
Let's quickly summarize the crucial takeaways that every single vestibular physician should lock into their clinical practice from today's explainer. First off, AIED is defined by bilateral, rapidly progressive, fluctuating, and steroid-responsive SNHL. That makes it a highly treatable cause of progressive deafness that you really do not want to miss. Second, the historical literature from McCabe in 79 all the way to the HSP70 marker firmly established this as a discrete, recognizable entity. And finally, distinguishing between primary and secondary AIED matters immensely for how you manage your patient, simply because roughly a third of these folks are dealing with an underlying systemic autoimmune disease.
So, knowing all this, how confident are you that the last idiopathic bilateral hearing loss case you saw wasn't actually a missed case of AIED? It's definitely something to think about. In the next episode, we examine the pathophysiology and the clinical red flags. Visit AustralianDizzinessClinics.com for the full review and companion materials.